Hello, my name is John Brennan. I'm a general practitioner and quality improvement faculty with the Royal College of Physicians of Ireland. You're very welcome to the latest in our series on COVID-19 pandemic quality and safety tools. Today we're going to be talking about person-centred care, mainly from the perspective of the patient. We will talk about person-centred care and providers in a future presentation. Today's talk is going to cover some basic person-centred care theory. It's going to cover some examples of person-centred care in action at the moment in COVID-19 times. And we're also going to have a look at how we can use these examples and person-centred care approaches to design a more person-centred future for our healthcare system, including or incorporating our new reality. So let's refresh on our definition of person-centred care. This definition comes from the Health Foundation and it is based on 4 principles. So person-centred care is care that is coordinated, it's care that is enabling, it's care that is personalised, and it is care that is delivered consistently with dignity, compassion and respect. I think that this quote from Valerie Billingham probably completes the definition. Nothing about me without me. So in designing a future for a more person-centred care system, for a more person-centred system, we should always include patients, family members and carers in what that system should look like. More on that a little bit later on. Why is person-centred care important? Well, there's a good evidence base that shows that providing care that is more person-centred improves clinical outcomes with less emergency department visits and better adherence to treatment plans. There's higher care satisfaction both on the part of the patient and on the provider, with patients more likely to choose less costly and less invasive interventions. Patients who are cared for in a more person-centred way are more likely to engage in positive health behaviours and as a result have better outcomes, and staff are more likely to report higher morale and increased engagement. Our first example then from COVID-19 relates to language. This resource has been designed by Planetree International on the language of caring. And what they've identified is across society, and as we are seeing in healthcare, a lot of people are using war, battle or military related terminology to describe the COVID situation. Obviously this terminology is in widespread use, but is there a way that we could change this language or our approach towards communicating with patients that might engender a greater sense of person-centred care? Obviously communication is core to delivering person-centred care, so we want to try and optimise that. Some of the terms that I've been hearing even from healthcare professionals include on the front line and in the trenches. We should be considering alternatives like direct caregivers or working directly with patients at the point of care and at the point of service. We're not at war with COVID-19, and I suppose war and that terminology has other very negative connotations for people. It is a new epidemiological reality that we're going to have to work with and around for the foreseeable future. So it's important that we try and use every tool at our disposal, including how we communicate with patients, to try and engender a sense of care and compassion. Some of the other alternatives listed here include physical distancing as opposed to social distancing, sheltering in place as opposed to forced or controlled lockdown. A key one in the centre there is again remembering that every person that suffers with and dies from COVID is a person first and foremost with an illness or a problem that they need help with. And again, they should never be identified or labelled with that diagnosis as being their identity or any other colloquial term that dehumanises or depersonalises depersonalizes them. Again, a huge concern for patients, their family members, and residents in long-term care at the moment has been around visitation. So are there other ways that we can phrase restrictions around visitation? So rather than saying absolutely no visitors, can we say visitation is temporarily suspended? The reasons or the why that is, and also highlight exceptions where they exist for compassionate reasons. Some wonderful innovations in personal protective equipment in making that more person-centered. This face mask designed by a student in the US has a clear plastic window, and she designed it with people with hearing impairment in mind. So people for whom lip reading is essential in communication. This is a team looking after patients with COVID-19 in Beaumont Hospital. And again, they recognised that in their personal protective equipment, their faces were almost completely obscured. And to help their patients identify them and identify with them in order to connect with them, they started printing each day their faces, or a picture of their faces, from a normal printer, and writing their names on their personal protective equipment. Patients reported that this made a huge difference in relating to their clinicians, knowing what they looked like and who they were talking to. At a kind of a population level then, there have been huge efforts put into enabling the general population and public to prevent the spread of COVID-19 through information campaigns and reinforcing important public health messages around cough etiquette and hand hygiene. One of the resources that we've been using in general practice, again, that enables people and patients to self-care more effectively at home is advice that's been published on self-isolation. So for patients with a confirmed diagnosis of COVID-19, or for people with a probable or suspected diagnosis awaiting testing, information like this goes through all the details that they need to enable them to self-care at home, including down to details like laundry and what to do with bins and that sort of thing. And then in a broader sense, we have been making much greater use of technologies that have been around for a very long time to enable access at a time when there are much more stringent controls in place to reduce infection and spread of COVID-19. And again, across the healthcare system, we're seeing people turn to technologies like the telephone that have been around for a very long time, but also video consultation, email, text message, all of these different ways of connecting, which again is about opening up access and enabling access for people who need care. In terms of kind of personalising and bringing some compassion into the situation, then these are two examples from Cork University Hospital and Sligo University Hospital around offering a facility for family members and friends who would like to visit patients in hospital instead to write to them, and that the hospital is taking it upon themselves to collect and deliver this correspondence to patients where visitation is not possible. And this initiative from Our Lady of Lourdes Hospital in Drogheda from the neonatal intensive care unit is where staff have actually taken it upon themselves to start keeping diaries for those tiny babies at present, unfortunately, unable to be visited the way they would otherwise be visited. And these diaries are designed to capture very important and special moments at the beginning of their lives, to be shared again when time allows. The final example then that I'll show you of person-centered care in action at the moment, of excellence in that sense, of innovation and of ingenuity, is this example from the Netherlands, where building contractors and companies are lending residential care settings cherry pickers, so that visitors can visit loved ones at a safe distance at higher floors of the building without those loved ones necessarily needing to leave the the safety of their own room in that residential care setting. So again, you're seeing examples where people and the health system at large is trying to produce care that is enabling, personalised, delivered with compassion, dignity and respect, and is evolving and innovating at a very rapid pace in order to try to do that, despite the distance or the wedge that COVID-19 tries to drive between clinicians and patients and their families, and how it disrupts some of those other aspects of person-centered care that many of us up to this point have taken to a degree for granted. I suppose more excitingly and more positively, and looking forward from there, there is a huge opportunity here to design, I suppose, the near, medium and long-term future in a more person-centered sense, now that we know that COVID is going to be a part of that. So to adopt a 4D design model, we should look at and think about these examples of excellence, also examples where person-centered care maybe isn't working particularly well, and to discover what really matters to patients, their families and carers. We can use some of the systems understanding tools that we've spoken about in a previous talk with patients and family members to do this. This helps us then, I suppose, to define the problems and to look at solutions and aims that we can develop. And in developing those solutions, we should be thinking about testing and learning, and learning from that testing to iteratively improve and embed greater person-centered care approaches in order to deliver, as we said, a more person-centered care system and environment. So where are the opportunities for designing a more person-centered health system? Well, if you take our broad heading then of dignity, compassion and respect, obviously we've spoken already somewhat about the verbal communication element, and that has had to change to a degree. We're doing less communicating in person, we're doing more communication remotely, we're doing more communication through face masks and that sort of thing. So we need to make sure that that's optimized as well as it can be. We also need to be thinking about other forms of communication and how that has changed. So, if people are no longer able to use or to appreciate facial expression, if people, are relying more on tone of voice to pick up cues in kind of compassion and care, and then also body language. Body language changes when people are practicing, greater infection control and wearing personal protective equipment, and we need to understand this and think forward about how we can actually optimize these forms of communication to make sure that care is delivered as well as it can be. From the point of view then of the environment, obviously where there's a risk of surge and lack of capacity in the healthcare system, we need to make sure we're still laying things out as well as we can to make sure that care can be delivered in a dignified and respectful way. And also then for patients approaching end of life in these situations, making sure that we make every allowance we can for family members to be present at that time, and also that we're optimizing the environment for privacy and dignity, as we said. Also, we need to be thinking forward about designing for staff and how we support them, because staff that do not feel themselves treated with dignity, compassion and respect are going to find it almost impossible to deliver care that holds those through values as being core. In terms of enabling care then, as we said, we've touched on this idea of access and how that has changed. And we can think about this in both a synchronous and asynchronous way. So synchronous or live access by telephone, video consultation, and asynchronous access, though, and what role that can play through text message, through instant messaging, and through email. We also then are learning an awful lot about self-care right now in a population motivation sense, and how we can support that, not just for COVID-19, but for other conditions that people are suffering with right now and don't necessarily have access to the healthcare services they had access to before at the present time. And then we should also be thinking about how we can use patient-reported outcome measures as an alternative to some of the objective measures that clinicians tend to use when assessing or monitoring how a patient is doing in terms of their treatment. So an example of this maybe is using patient-reported pain, function or inflammation scores, as opposed to bringing patients into a healthcare environment where they're at risk of picking up the disease in order to take monitoring inflammatory marker blood tests. Our third then principle of person-centered care, coordinated care, I suppose is very illuminating also in how we are now seeing clinicians and patients coordinate care remotely, how clinicians are communicating with one another at every level of the system, and how in a system sense a lot of the previous silos that were there have been broken down in order to enable a more integrated approach to managing COVID-19. You know, in a kind of system to system sense, what we're seeing is much less you know, admission to and discharge from you know, secondary, tertiary care, and more a handover of patient care between those care settings happening, particularly when it comes to COVID-19. And I think there is a much greater role in the future when we are designing how other conditions are cared for that type of mentality. We need not adopt the silos that we had before. We should maximize the relationships that have been newly established and built around managing COVID-19 to optimize coordination of care in a person-centered care sense. And then finally there, in coordinating care is what we're seeing in communities right now, between patients, their family members, their carers, how they're pulling together to mind one another while maintaining those public health recommendations that are there to slow the spread of the virus. We've had examples of patients contacting other patients within communities with positive diagnosis of COVID-19 even before the contact tracers have gotten to them. So again, there's an incredible resilience and there's incredible you know, there's an incredible well of ability there in people in looking after themselves and each other, and that's something in healthcare that we haven't really tapped into fully or appropriately yet, and that is something we should be incorporating into our design models for the future. And finally then, our final principle is that person-centered care is personalised. So what we are seeing now in a decision-making sense in the acute phase of all of this is that when it comes to looking after COVID-19, the decision-making is being done for people based on how the system is operating, which other parts of the system have been postponed or shut down for a period of time, and how COVID-19 is being looked after in a more integrated way. As things unlock or unwind again when it comes to COVID-19, there's going to be a much greater role for shared decision making, and I'm going to talk about that in a little bit more detail now in a moment. But in that sense, the complexity of decision making has just increased yet again, because we are now bringing in the risks and benefits of attending a healthcare setting for people with chronic disease and comorbidity, and having to layer that or line that into the other decisions we share with patients around treatment options. So again, you know, we are having to kind of dig deep into this question of not what is the matter with you, but what matters to you as we look towards making these decisions. And we've already had quite a bit of experience in general practice around patients who have been due over the last few months for routine monitoring investigations and that sort of thing. And we've shared a lot of decisions around postponing those investigations for now based on what patients tell us matter most to them. And again, in order to really achieve you know, truly shared decisions, that underpinning of psychological safety is absolutely essential. you can have another look. You can have a look at the other talk that I've done on psychological safety for this series to get a little bit more detail. But essentially, what that means is trying to minimize or reduce that sense of interpersonal risk between clinician and patient, so that both can be honest and truthful and trusting in one another in having these conversations. So this slide, which I've borrowed from Doug Eby and South Central Foundation in Alaska, is an illustration of the relationship between control over decision making and acuity of the situation. So you can see that in situations that are less acute, customer owners or patients and family members have a greater degree of control over what happens in their health and care. But as the situation becomes more acute or in more acute situations, the system tends to make decisions for them. So an example of that, say, is a major trauma where you need emergent care to save your life. You're less likely to be sharing decisions about that care as things have to happen very, very quickly to potentially save your life. And where we have placed COVID on this curve at present in a societal sense is way over here on the right. So we're treating it in its entirety as it should be, as a very acute situation. And as a result, the system at present is still making most of the decisions for people on how they should be looked after while COVID is here. And what is going to happen as restrictions ease is that this is going to move back more towards the left and more towards a situation where there is a possibility for the system and or its clinicians to share decisions again with patients, again with that added layer of complexity around what the COVID-19 situation is at any one given time. Shared decision making then will dip in here in a little bit more detail, because again it's very relevant now. It's going to be increasingly relevant over the next few months and is an essential person-centered principle that we should be trying to embed as we design what care is going to look like. So shared decision making is a two-way relational process of helping people to reflect on and express their preferences based on their unique circumstances, expectations, beliefs, and values. The model for shared decision making that I use is one from Glenelwyn, and it incorporates three separate steps: choice talk, option talk, and decision talk. For choice talk, the first part is all about stepping back. So now that we think we have a diagnosis, let's take a second to create some space to share a decision on what we do next. Offer choice. As in put choice out there on the table early on in the discussion, because lots of people still are not used to being offered a whole lot of choice, and justify that offer of choice as being because first of all, we have choices, number one, and these are choices that we can match to personal preferences, but also because we have to acknowledge all of the uncertainty that we all work with all the time in how different people and their situations and their treatment come together to produce good outcomes or not, and the unpredictability that we often have in those situations. Check reaction to that. Again, because some people again are just not used to being offered a choice in these situations, and again through this COVID-19 pandemic, people's choices again have been greatly restricted. So it's going to take a degree of work as we open things up again to bring people back into that mindset and defer closure. So rather than maybe a patient saying, "Okay, you're the expert, you're the doctor, tell me what to do," think about again deferring that point of closure by offering the advice that often we find that patients who are willing to play a greater part in the decision-making process often choose a treatment option that suits them better and results in a better outcome. For the option talk, it's important to start by checking knowledge. Patients have often read around a different suspected diagnosis or treatment option on the internet, or have heard things from other people, positive or negative. It's important to get back on the same sort of footing there where you can. And again, we know that some of those resources are more reliable than others. And we also know that there is a lot of information out there about COVID-19, for example, that people are getting from unreliable sources or whatever. So it's important to get all that knowledge out there in the beginning of the option talks, so that you're both standing on as equal a footing as you can. List the options as a heading first and foremost, and then describe them in a little bit more detail, particularly in a comparative sense, and trying to build in the context where you can of that person, what you know about them, and what you know matters to them based on what they've already told you. Provide decision support tools where you can. So we don't have decision support tools developed yet really for COVID-19 situations for the patient on their side. We do have some decision support tools developed for clinicians, but on the patient side and what different treatment elements may involve, we don't yet have patient decision support there, but we do have patient decision support for a lot of the other conditions that we're going to need to manage over the next number of months. So we should be trying to use these again as a way of enabling patients to take a greater part in the decision-making process, and by sharing information, and then summarize those options. As we move then to decision talk, the key part here then is eliciting and focusing on preferences. So asking that question, what matters to you, and bringing or aligning the options, the treatment options, aligning them towards that preference together where you can, to move to a decision. And again, decisions don't have to be made instantaneously. A lot of the time people want time to think about these things, so we can offer a review or we can defer closure for a little bit longer. So as we said, shared decision making is going to be an essential component of how we make care more person-centered over the coming weeks and months. With that extra layer of COVID-19 to add complexity, I think it's really important that we try to think about structured ways of achieving shared decisions through things like choice talk, option talk, and decision talk, all underpinned by that psychological safety, as we said. Moving on then to co-production, a term coined by Paul Batalden. This is defined as the interdependent work of patients and professionals to design, deliver, assess, and improve the relationships and actions that contribute to the health of individuals and populations through mutual respect and partnership that leverages each participant's unique assets, expertise, and actions. So not only is this a wraparound approach to improving health and care at the individual level, but this is also an ethos that we can adopt when we think about designing and improving healthcare in a general sense to make it more person-centered. Co-production, I suppose, is top of the ladder when it comes to how we try to do things to, for, and with patients. So coercion and education or unidirectional instruction is down at the bottom of that ladder. Informing, consulting, and engagement, which again is often quite unidirectional, but with the option of questions and answers maybe for involving patients and family members, is in the middle. And at the top of that ladder then we have co-design and co-production, which is bringing in a degree of design thinking, number one, as we discussed a few minutes ago, in discovering, defining, developing, and delivering, but also a sense of agency on the part of the patient and their family members and their carers in how we can enable enable and bring forward their courage and the power they have in the decision-making process, or how we can design services that incorporates their input as an equal stakeholder. So in over the coming weeks and months, what I would really love to see, and I hope you feel the same, is that we can incorporate quality 1.0, 2.0 and 3.0 together to bring about this future, and not necessarily have to evolve from the start as we have done previously by starting with accreditation standards, guidelines, or being at least this good to get to improvement and thinking of systems and processes, variation, leadership and motivation to be as good as possible, to then get to co-production, which is all about relationships and actions, equal stakeholders, the lived reality of the individual, formerly known as patient, the as-is system journey, integrated care thinking and systems, and this idea of value-based healthcare. So being good enough based on what really matters to the patient. And what I would love to see is, rather than have to build from the bottom as we have done previously, to get to the point where we were just before COVID, I would love to see that we would be able to dip in and out of all three of these elements as we need to in designing a higher quality, more person-centered health system for patients and providers alike. So let's jump as high or as far up that ladder of co-production as quickly as we can in order to achieve a truly person-centered care system. So in summary then, and a few top tips from me before I leave you, our 4 principles of person-centered care from the Health Foundation are care that is coordinated, care that is enabling, care that is personalised and delivered always with dignity, compassion and respect. As we think about all the different new systems that we have to implement and improve and change over the coming weeks and months, please think about them in terms of these 4 principles and your patients, and see what way they can be adapted and improved to be more person-centered. Let's focus on and learn from some of the positives that are out there and the examples of excellence that I shared with you earlier. Person-centered care is still possible, no matter how acute the situation. Let's start to think in terms of design and the opportunity that we have to make care more person-centered in the weeks, months and years ahead, taking COVID-19 into account. And let's base that on the most important unit of interaction between patients and clinicians. This idea that power and decision-making should always be shared, and that should be shared based around the options available and what really matters to patients. And finally then, let's think about incorporating Quality 3.0 and co-production from the very start, not just as an underpinning philosophy for how health and care can be optimized in a person-centered sense, but also how we can design and improve together patients, clinicians, managers alike, a more person-centered care system in the time ahead. Thank you very much for listening.